Our next speaker has been a physician since 1995. He completed his internal medicine residency at the Detroit Medical Center, followed by a fellowship in endocrinology at the esteemed Cleveland Clinic. Dr. Elzo Haley currently serves on the faculty of the Wayne State University School of Medicine and maintains an endocrinology practice with offices in Dearborn and Southfield, Michigan. He is licensed to practice medicine in both Michigan and Ohio, and we are privileged to have him here with us today. Please join me in welcoming Dr. Opada Elzo Haley.
Thank you all for staying so late. This is the last talk of the day, I think, so but he's gone. So this is a different talk. This is Dr. Elzo Haley, an endocrinologist. This is talking about the newest of the pump, the newest of the sensor, and the newest of the pump that talk to the sensor to see how these new technology can help you if you have diabetes, how that new technology can help you. So we'll start a few slides talking about a few things about diabetes in general. This is one of the slides I usually start with because it's always difficult when patients ask why we can't get rid of diabetes. So we're talking here type 2 diabetes, for example. Why is it complex? Why we have 28 million diabetics in this country and we have 58 million with pre-diabetes? It's very complex. I mean, we're probably looking at 90 million diabetics in the next 10, 15 years. That's 25% of the population. It's the only disease that are actually out of control on the CDC websites because of the prevalence. And because of this, it's very difficult. We think diabetes is a pancreatic disease. It's true for type 1. The pancreas doesn't produce very well. So we have two kinds of diabetes. Type 1, where these antibodies attack the pancreas, and the cells will stop producing insulin. And now the only way you can replace it, either get new pancreas, new beta cells, or replace the insulin, and a different way of giving the insulin back. But type 2 is different. Type 2 is a complex disease. It's a disease in the pancreas where you can't make enough insulin and produce too much glucagon, but also a disease in the liver. In type 2 diabetes, the liver puts out a lot of sugar. That's why some patient asked me, my sugar was 80 last night. I wake up in the morning, it's 180. Where did the sugar came from? You see, it came up because your liver puts out sugar overnight. The way we stay alive when we don't eat is our liver puts out sugar. It takes fat and protein from your body, change it into sugar, and keep the sugar normal overnight. That process is uncontrolled in type 2 diabetics, and that's why you have high sugars in the morning. That's gluconeogenesis. In type 2 diabetes, our liver don't work very well. Neurotransmitter, the brain of type 2 diabetic doesn't function very well because they're hungry all the time. And they have also a different sense of low sugars and high sugars. There was drugs in the past were made to actually affect these neurotransmitter function of the brain to help type 2 diabetes. Picture next to it the muscles. If you just had any food, the insulin will take the food first step to the muscles. So the muscle's supposed to take that glucose, burn it, and use it. Type 2 diabetics, they have problem with their muscle taking the glucose, so decreased glucose uptake. So they mean the muscle, so when the glucose comes, the insulin cannot do anything with it, and it has to take it to the next step, which is the kidney, which is also a problem in type 2 diabetes. The kidney don't work very well. Usually kidneys will help you get rid of the sugar, the excess sugar in the body, but if you have type 2 diabetes, your kidneys like to preserve the sugar. So instead of secreting the sugar, it will reabsorb it, even if it's at 300. And the last one is fat. Sometimes we see why there's more people have diabetes. Is it the weight? Is it people have more central fat? That's why there's ethnic variation in type 2 diabetes. And it's not always the weight. Sometimes you see people that are so overweight, but you don't get any medical problem, no heart disease, no diabetes. And sometimes you see people are just average weight, but they have a lot of problem. Because it's not about the weight anymore. It's really distribution of fat. Where is the fat? If you have more central fat, that fat is an active endocrine organ that produces cytokines that will affect and cause diabetes. So that's another organ also involved. The more central fat you have in your body, the more trouble you're going to have with diabetes and the complications like heart disease and strokes and eye disease. The last one is the incretin or the GI tract. The duodenum, the stomach, all involved also in absorbing of sugar, secreting a hormone called GLP-1 that handle our sugar. If we don't have enough GLP-1, then we can't handle the sugar very well. GLP-1 act like the sensor. So when you eat, the body knows that you ate because of the GLP-1. GLP-1 goes to the brain, tell the brain that you ate. It goes back to the stomach and give you that fullness feeling. GLP-1 goes to the muscles to help the muscles take the glucose. The GLP-1 goes to the pancreas to produce insulin, decrease glucagon. So it does all the right signals. People with diabetes do not have enough GLP-1, or it doesn't work very well for them. Even people with family history of diabetes have a problem with the GLP-1. It doesn't work very well for them. That's why a lot of times they just feel hungry all the time. They don't feel full because of the lack of the GLP-1. So that tells you we have so many organs involved in type 2 diabetes. That's why it's hard to treat and hard to prevent. Next slide. Also at the same time, because of all these diseases in the different organs, all the pressure goes back to the pancreas. So now the pancreas, when you have type 2 diabetes, just new onset, you lost 50% of your beta cell. So you can see here, by the time you have somebody with new onset diabetes, type 2 diabetes, 6.5 A1C, that person lost 50% of the beta cell. And as you go on, you lose more and more of the beta cell till you have no beta cell left, and type 2 becomes like type 1 and you have to be on insulin. Next slide. This probably do quickly. This is one of the problems we have, this beautiful scene of donuts. Next one. That's why we can't control diabetes. Next, another nice food picture. Next one.
No grading sugar.
And the problem, sometimes you say, why are you, doctor, why are you so upset about numbers? Some patients say, my sugar was 180 this morning. And I tell them, no, that's bad. Sometimes we think the doctor is so obsessive with numbers. It's not really about the numbers, because we have data that say the higher your sugar is, type 1 or type 2, the more complication you're going to have. We have lots and lots of data. The higher your blood sugar, the more disease you're going to have in the eyes and the kidneys and everywhere, including the heart risk. And we also have data that if you control your sugar well, then you have less complications in terms of the heart disease. This is all the study. Next few slides here showing these newer studies. I don't know if you heard of these. This was actually big news on the CNN at some point, because the ACCORD trial, the next two slides also, ADVANCE and the VADT trial. All these trials showed that aggressive sugar control was not good to prevent heart disease. And everybody was disappointed. So what's the use of controlling my sugar? So we had to go back and see why we failed in these trials to show improvement. And I'm going to show you next slide here. But bariatric surgery, for example, can cure diabetes in 100% of cases. So how to understand these data? Let's go down. Another slide, next slide here. Type 2 diabetes is a complex disease, and it started like history like this. And I know some of you have type 1, but we'll get back to this. You can see here, if you have family history of type 2 diabetes, you inherited insulin resistant. And with poor nutrition, weight gain, and no exercise, that goes into impaired glucose tolerance, or what they call prediabetes or borderline, then you become diabetic, and then all these complications happen till the end stage diabetes. So in order to prevent heart disease and complications, we noticed that the best way to do it is to be aggressive as early as possible. Hopefully before you get diabetes. But if not, at least as soon as you get it, you need to be aggressive in controlling well. If we wait till the complications happen, people sometimes don't wake up with diabetes till they can't see. The doctor tells them your kidneys are not working very well. Now he's awake. Now he wants to do something about it. It is too late at that point. It's most of the time you want to do it early in the process. If you have diabetes, you have family history of diabetes, that's the best advice to tell them. If you don't have it, try to prevent it. And if you have it, try to be aggressive in treating it early to prevent these complications. Next. It's a good nutrition. It's one of the, I know the slide is there, just good nutrition, always good. Next one here, showing what's called survival as a function of A1C. A really important slide for patients because sometimes you say, what is the goal? You know, A1C, which you had several talks about A1C today. It's an average blood sugar for 3 months. So what is the best A1C for somebody? It used to be 7 for everybody. Now it's really become a more individualized goal. So not everybody 7 is good. 7 may be very bad for somebody, depending on the medicine they are. You can see here it's almost a J curve with oral agents or oral insulin. So if you take insulin, aggressive number in the 6% may not be as good for you. So your goals are a little higher. So now American Diabetes Association becoming with this individualized goal. What is the best for a person? So somebody who lives alone and one hypoglycemic episode can they may not wake up from it because they're alone. Their goal of A1C is different than a young person who's healthy who can get A1C down to 6% without any hypoglycemia. So it's really all about the hypoglycemia. You just had a great lecture on hypoglycemia. So the next slides here, looking that it's really not only the A1C anymore. What is more important than A1C is glycemic variability. What that means, if your A1C is 6.5% and your sugar go from 30 to 500, that's not good. Changing of the sugar, this 40 to 100 to 300-400, their variation is what causes a complication. You want sugar to be as narrow in the normal range as possible. So one number A1C does not really help that much. You want to make sure that you are at goal all the time with less of these variation of sugar. That's what the meaning of this. So you can see A1C is similar to those two pictures, but you can see that person have 50 episodes of 30s and so many episodes of 500. That's not healthy A1C. There we go. I don't know what their picture for, but let's say put dog's picture, people like it. So in order to, we want to talk about, or we're going to jump to technology. In order to give insulin, we have to understand how does normal pancreas give insulin? And that's sometimes confusing to people. Because they say, if I'm not eating, why do I need insulin? Normal pancreas, if you don't eat, produce insulin 24 hours. You can not eat for a week, and your pancreas will still give you insulin. Because that little bit of insulin, 24-hour basal insulin, is important to help you with a lot of functions in the body. Decrease that sugar production from the liver, handle so many functions in the body. And then as soon as you eat, you will have a peak of the sugar to cover the meal. That's why we call this basal insulin, like Lantus, Levemir, MPH, and the prandial insulin, the quick-acting insulin, Humalog, Novolog, Epidra, Old Regular. So we want to give the insulin to a patient who doesn't make any insulin. You want to mimic normal physiology as much as you can. Next. So next again. So in order to do that, we do this, that's why we tell patients you have to take 1 shot of basal insulin and 3 shots of quick-acting insulin. But there's a problem with this, because basal insulin, all the good insulin we have, Lantus, Levemir, all of these, the best of them, if they work flat like this. But our normal production of insulin is not flat line. It's varied by age, as you see here. When you're younger, by 4 o'clock in the morning, your hormone will start producing for male or female. If that happens, your need for insulin are much higher because now growth hormone, cortisol, ACTH are higher. So your basal need of insulin are different. When you start losing gluconeogenesis as you get older, your basal needs are different. So depending on the age, depending on the patient, depending if you have a normal kidneys or normal liver, your basal needs may be variable all day. So an insulin that's flat 24-hour may not be great for you. Because once you do the shot, you're stuck with that 24-hour insulin. As we're looking for better ways, better insulin, and ways of delivering the insulin in more physiological, just like a normal pancreas would do. The next. There's another problem with the older insulin, something called intra-subject variability. That's something you will notice as diabetic. You give yourself the same shot. For example, you get Lantus 11 year, you get 30 units at night, and you wake up in the morning, and one day your sugars are 90, next day you're 160. You say, what's happening? I'll give the same shot, same place. There's something called intra-subject variability where they mean it was studied, where they have them in research, where they actually give a nurse will give the patient a shot, and everything is perfect. Despite that, you will have different absorption for that insulin. And because the skin, technique, the needle, the temperature, there's so many variables, but the most important variable in terms of the different absorption of insulin is the skin. We're not made to inject insulin all the time. The skin can handle it. And if one of the mistakes I see usually with patients, I tell them, right-handed people, when they take insulin, I tell them in the clinic, how do you take insulin? And most people do exactly the same spot because it's easy. We tell them to rotate, but when they rotate, they do it like this. That's a rotation. If you're doing 4 shots of insulin a day, you'll be out of space because you're going to the same location. And this, more and more of these injections cause damage to the skin and the dermis underneath, that you don't have blood vessels. So you inject the insulin. I took 30 units. It didn't do anything, of course, because it's going into a fibrous tissue that is absorbing the insulin. So we tell people to rotate. I mean, rotate, you have to really do the extra effort to use all these areas, use the legs, use the arms, so you don't damage the skin. Repeating injection in the same place causes damage to the skin and causes this intra-subject variability. The variable absorption is very annoying to patients usually. And this is what we're afraid of, complications. For example, blindness. Don't worry, everything's great, the turkey in the microwave and I'm feeding the baby. Very good. Some complications. That next one. That's a horror movie. This next one. So in order to get a better delivery of insulin, 30, 40 years ago, people thought, well, maybe can we do an insulin pump? So actually we deliver insulin just like normal pancreas, a little bit at a time instead of too much at one time. This was the first pump. So if you look at the new technology, this was 30 years ago. Actually, this person carried around and they was giving him insulin. I'm not sure how his life was, but it didn't last long. But now we have so many of new pumps. We have several companies are making pumps. So the pumps again are smaller, nicer, easier to handle, touch screens, cooler looking pump. So especially for children, it's really these pumps are becoming a much easier, user-friendly, and the only one wireless is the Omnipod. Everything else is a wired pump. Next one. So insulin pumps, sometimes people think that insulin pump is only for type 1 diabetes. I try to get every single patient with type 1 diabetes in my office on a pump, because I don't think you can never give the same insulin with injection as a normal pancreas. With the pump, I'll show you slides later why the pump can give you perfect delivery of insulin if it's programmed right. But also people don't think that it's good for type 2, because as I showed you in this slide, beta cells in the pancreas go down. If you had diabetes more than 10 years, and you've been on 4 shots of insulin, most likely you have no beta cells. So you're actually just like type 1. You have no beta cell, and you have no pancreas making any insulin. Now you have to deliver insulin exactly like type 1, like a normal pancreas. For example, for pregnancy, children. One of the things with nanotechnology is a lot of the parents, and Dr. Akata, pediatric endocrinologist in our office, we see that all the time also. Parents are so afraid from hypoglycemia. So when they try to develop diabetes, some of them, the first few months, they don't sleep. They're always kind of afraid. What if my son developed hypoglycemia and I don't know about it? What if he dies from hypoglycemia and I don't know about it? So they actually a lot of mothers and fathers, they wake up 6 times at night and check in make sure that the children are okay, they check the sugar, they poke their fingers, so it's very scary for them. We do this monitor and we have twin brothers who are sugar is always perfect till 3 o'clock in the morning. We notice on the monitor that it goes to 300, both of them at the same time, and we don't know what happened till we realize from the other brother, bless you. The mom is so afraid that at 3 o'clock in the morning she wake up both the twins and start feeding and just stuff food in their mouth till they can't breathe and then go back to sleep, and they will get sugars in the 400s from 3 o'clock to 7, 8 o'clock. So it's, again, having pumps and eventually having sensor that a monitor that check the sugar all the time and beep when the sugar is low or beep when the sugar is high can save your life, can also for the parents, or the other side also if you worry about somebody else, a family member. What if my wife, what if my mother, I'm afraid of the hypoglycemia, then having that sensor will give you comfort because it will beep when the sugar is low. Next. I have patients who are on dialysis. So on dialysis day and non-dialysis day, the need of insulin are completely different. You can't do that with the shots. With the pump, you can have pattern A for dialysis day, pattern B for the non-dialysis day. For kids, you need pattern A for school days, pattern B for weekend. People eat differently on the weekend than on a weekday. So you need different pattern. You can do that with the pump, you can't do it with the shots. People are different shifts. Some people work half of the week day shifts, other half of the day are night shifts. Also, you need different regimens. You can't do that with the insulin, you can do it with the pump. Gastroparesis is one of these complications of diabetes where you don't absorb food very well and you will have variable sugar levels. And the only way you can actually control sugar that way is with the pump and sensor. Next. So we think that pump is only for somebody who looks like educated, very smart. Next. But it can be anybody. If you train well, if you understand it, pumps are becoming again simpler and simpler to handle. And to apologize for this picture, the next slide is a cute picture. It's a dead, disturbing man. Next one. So this is what the pump will promise. Why it's different again. So go click a couple times. I'm sorry? So with the insulin pump, with the basal insulin, instead of giving the shot to give you 24-hour, now with the insulin pump, you can program it 24-hour. So for the hormone changes in the morning, I'll give you higher basal rate. If you're exercising in the afternoon, I'll give you lower basal rate. If you're working different schedule, your basal rate at work is different than the other base. So you can have variable basal rate. If you give a shot of an insulin, long-acting insulin like Lantus or Levemir, you will have 24-hour insulin. You really can't change the insulin delivery. Once you give the shot, you're stuck with it. For the pump, it's not. For the pump, it's delivering insulin at a time. Till at some point you say, well, I think I'm going to exercise in the next couple of hours, or I'm not hungry in the next couple of hours. So you can lower your basal rate to 50%. You can completely stop the pump for an hour or two. So things you can do with the pump to prevent hypoglycemia, which is really the ultimate, is we need to prevent hypoglycemia to have a better result with diabetes. So you can do that with delivery of insulin through the pump. Again, when you do a shot, you're stuck with it. We get sometimes phone calls from the patient to our office. So by mistake, I took 30 units of insulin instead of 10. What should I do? Unfortunately, there's no way you can go and take that insulin out. You're stuck with it. You just have to eat. Sometimes I wonder that maybe patients do it on purpose so they can have an excuse to eat. Children do that, by the way. They love that because now they have excuse to eat all the candy in the house. They love to do this. But again, with the pump, that will not happen. With the pump, you can stop it, you can decrease it, or you can increase basal rate. You say, I'm start taking prednisone. You have a bronchitis, you go to emergency room, and they give you prednisone for 5 days. Prednisone raises your sugar like crazy. Or you have back pain or knee pain, and you go to the rheumatologist, and they give you a steroid shot in your knees or your back. Guess what happened to your sugar? Crazy high. But not all day. Depending on what kind of steroids you use, the sugars will be so variable, it's very difficult to predict and give the right regimen. With the pump, you can program it based days on that. You can go 150% of the basal rate while you're on the steroids, then you come back to normal after you feel better. Feeling sick, so any sickness will raise your sugar. So you need higher basal rate. When you feel better, you go back to the normal rate. Again, these things are a lot easier to do with the pump than the shots. Next. Next one here, just showing that the pumps actually do help. Next. Next also. The pump does help with preventing this. This is what's nice about the pump would give you. The second thing is the bolus. So we talk about different basal with the pump. Second thing is the bolus. For example, now you want to eat, and you calculate, well, I'm going to eat probably 8 units of Novolog or Humalog to cover my meal. Then 2 hours later you want to eat. You say, okay, I'm eating 60 grams of carb, I'm going to need probably another 6 units. But sometimes there's something called insulin stacking. Now you took 2 shots of Novolog within a few hours, and you only took Lantus 11 meal in the morning. You never know how these insulins are going to stack at some point, and next thing you know, you're crashing. Pump does not do this. Pump has something called active insulin time. If you see that, and I'm sorry, there was a clicker left in the car, but the point I would see the active insulin time, it's actually correct. So for example, you take a bolus and 2 hours later you want to give another bolus. The pump will calculate the bolus based on what is your sugar level, how much food did you eat, but pump will sense there is still 2 units left from the last bolus, or left from the basal delivery. So we'll deduct that amount. So instead of giving you 8 units, it will give you 5. It will deduct the 3 units. Yes?
You're saying pump calculates that?
Yes. What you need to do with the pump, you have to enter how much food you eat, and you check your sugar. And the pump, see, we program the pump individually. Everybody has a different program. But when you program it, the pump calculates all these things for you. All we have to do is how much carbs you put in. Even now, the new meters and sensors send the blood sugar to the pump, so you really all you have to do how many grams of carb I'm eating, enter the pump, and the pump does all the work. And that's the protection, is the correction factor is that also the active insulin time that is deducted. Next. We talked about the bolus delivery. If you take a Novolog, Humalog, or Pedra, your bolus delivery is like this. It's a straight line up, straight line down. Quick acting insulin, we like that. It works at some time, but you go into a reception, a wedding, something, or today, you may have a little snack when you came in. Hour and a half later, somebody have cookies. You eat some cookies. An hour later, somebody brought donuts. You're eating donuts. You are at a reception or a wedding. You eat hors d'oeuvres, then drinks, then food for 2 to 3 hours. How you calculate your bolus that way is very difficult, and you can't give a shot. So you say, I'm going to eat at this wedding 100 grams of carbs, and I need 10 units of insulin. You give them right away. Guess what? You didn't eat 100 grams of carbs. You're going to drop your sugar.
Yes.
Now with the pump, you can have different delivery of the boluses. So instead of delivering like this, you can have 4 different ways of delivery. And you say, well, it's too complicated. I think most of the things that you'll be trained on, and it'll be easy again to program it that way. So you can have, say for something like this, say, I want to give 20% of the bolus the first hour, 40% the second hour, 60% of it in the third hour. Or you say, I want to give a dual bolus that is just different. One phase in 1 hour, one phase in 3 hours. So you can program the bolus the way it's given. Remember I told about gastroparesis, and hopefully none of you have it. It's really bad complications of diabetes where you just, your stomach is upset all the time and you're throwing up all the time, and your absorption of food is variable. You may absorb it within 2 minutes, or you may absorb it in 10 hours. Can you look, there's a clicker in that. So the different delivery of the bolus it makes it a lot easier for you in different scenarios to give the bolus over 3 hours or quickly, depending on how you can eat. And also there's variables, so 1 second, I can finish this. There's different glycemic index. So there's food that is absorbed right away, you need a quick bolus, and there's low glycemic index food that is absorbed over 3-4 hours. So if you're drinking juice or having cereal, that's high glycemic, very quick response. But if you're having a pizza, that's 3-4 hours absorption. So your bolus is different. Again, something you cannot do with the shots. Yes?
Yes. I understand about gastroparesis. What I have is irritable bowel. Does that have anything to do?
Well, the same, irritable bowel, it's the same thing. You don't absorb very well because you may have constipation one day and diarrhea next day. You have beautiful stomach one day, next day you eat something wrong and you're throwing up all day. So that's response also make it difficult for absorption, and adjusting with the pump would make it easier. Next. This is something on these slides, you probably don't need to do this. So you're just calculating the starting dose, something we will be able to do it in there. You don't have to worry about these formulas, showing that there's ways based on your insulin need that can tell. Thank you. There's ways that we can measure and calculate how much exactly you need at a basal rate and how much you need for carbohydrate. So it's not a guessing number. There's formulas and science behind it. You don't have to know the numbers, just knowing that there's ways of doing it in the most accurate way. So when you're on the pump, one of the nice things that we can know exactly what you're doing if you're on the pump. You'll be able to download, when you download the pump, I can tell patients, okay, well, I know exactly what for example, patient, these are silent boluses, these are the blood sugar checks. So you can tell this person like to sleep for 14 hours a day. They do nothing here, and suddenly there's a lot of activity here. You can tell a lot of things also, different days. These are different days. So you can tell when the patient's on steroids or non-steroids, what happened. Sugar good here, bad here. Dialysis day, non-dialysis day, I can see the pattern and say, okay, I think we need to put you on a different regimen on these 2 different days. I will usually mark on this. Patients on this day is working at night shift, this day he's off. What is his sugar here? What is his sugar here? And how can I give him different regimens to adjust for these 2 different days? Again, people are not, nobody's boring. Nobody's doing exactly same thing every day for the rest of his life. Every day is variable activity for you. So with the pump, we can tell what you're doing every day, and we can adjust the delivery of insulin to fit your schedule instead of the opposite. Here's a shot, and I want you to change your life to fit the shot. It doesn't work that way. We all have life, we have things to do, and we don't like to do the same thing every day. So I usually ask our patient different. It's not like, and I usually also, when I give talk to the residents and fellows and other doctors, if you want your patient to comply with diabetes medication, you really need to first question, ask them, when did they have their breakfast, the lunch, the dinner? When do they work? When do they exercise? Write down all these numbers and then fit the medicine based on their schedule. Not the opposite way. Most people do it. Here's the insulin shot. Here's the medicine. And I want you to do 1, 2, 3, 4. So if you're not doing 1, 2, 3, 4, I'm blaming you. You're not doing your job. Instead of blaming me, not changing according to your schedule. I say, if you want patient to follow, don't mess up their life with this. Let me know how you live. Let me fix you with the right regimen that fits your life. Then it'd be easy for you to comply. Very few people do this. But when you do it, people like that. They just go to medicine around it. So we can tell from the pump also how many grams of carbs, how much food did you eat, how many boluses did you give, how much time did you have the pump off. To tell patients sometime with the pump, I can tell how many times you went to the bathroom. So we can tell everything about you from these pictures, but we can download the pump. And see, this is here, that's a basal rate. This person has 7 different basal rates. All these numbers are programmed. And you don't have, again, you're not doing any of that. The doctors will do it for you. And, or the pump educator. And to make it easy, again, we collect all these data from downloading the pump. So after we go from the pump to why the pumps are important, because you can link it to a sensor. Link it to a sensor. What makes the pancreas do? good job in a normal person is the pancreas has sensors. He knows what your sugar is, and he will give you insulin exactly the amount enough to cover your sugar. He knows when you're eating, and he gives you enough medicine to do that, to cover your food. But when you lose that, now you have to be that pancreas. So you can tell when did you eat and you give the shot, but you cannot tell when your sugar goes up and down. So trying to get closer to what we call artificial pancreas, we have the sensors. The sensors is another device that send information to the pump, so you can be any day, any time. You look at the pump on the screen, they say, oh, my sugar is this, my sugar is that, and you can predict your sugar. What's going to be next? And this is here showing why these continuous monitoring helpful. So if somebody comes give us the book and has all these sugar numbers, we can get some information. But if I get this, is what's the difference? If you give me the book and I see 4 sugar numbers, these are perfect numbers here. But what I don't know is what happened in between. How high did it go? How high did it go down? Between these points. The continuous 24-hour monitor will give me that information and give you that information. You can adjust your meals accordingly. So here, when the sensor beeps because it's going up, you will take some extra insulin and prevent it from going. And here it will beep before it goes too low, so it can protect you from low sugar. And so the sensor gives you that warning that it's too high or too low. And you can program it. There's so many different devices. They are the sensor sending wireless information to the pump. So you can tell exactly what's going on, and your pump can tell what to do. There's different form of devices. This slide is important to know with these sensors, if any of you have used before, has a delay reaction of, because it's only measured the sugar from interstitial space. But when you poke your finger, you're actually getting from the blood. There's 15 minutes delay. So the sugar you see at the sensor is that your sugar 15 minutes ago. So it's not 100% accurate. That's why you always have to confirm with the poke. But what is important is to see the trend with these pumps. So the trend is, see, when the sugar goes up and down, you can adjust based on this. Now these 3 slides showing these 3 days monitor we put in the office. These 3-day monitor check your sugar 24 hours, so I can know exactly what happened. If I added new medicine, what happened to your sugar in the 3rd day? This is a person that came to the office who take insulin at night, and he swears he never had hypoglycemia. This person is only 32 years old. Over 100 episodes of hypoglycemia at night. And you say, why he's not feeling it? Because you just heard the lecture before me. When you get hypoglycemic episode, your brain will start decreasing the response to it. So when you have a lot of them, you can be 10 and you have no symptoms. And so people get surprised. How come I didn't know I had hypoglycemia? And a lot of people say, well, no, this person, I don't have a single episode of hypoglycemia. This is a 3-day average. Lots of hypoglycemia, and this is overnight. It's very serious. This is sugar below 30. If your sugar drop below 30 at night, you can die without knowing. With these sensors, again, you can tell this is what happened. You can adjust your medicine. It's shown here when we adjust medicine, I will show how these sensors are helpful. So the last part of the talk is the newest pump, which is the 530G. This is the newest pump because the first step into this smarter pump that actually will stop working when your sugar is low. You didn't have that before. This just came out, just approved by FDA a month ago. This is called the threshold suspend. And you can program. Say, I want the pump to stop working when my sugar is 100 or 80 or 70, or you can put any number you want. So it can protect you from hypoglycemia. That's the 530G. So again, the first step towards stopping the insulin. So sugar is coming down on the sensor, so the pump stops working for 2 hours, then it goes up again. But if it works and the sugar is still low, it will stop working again. Most people, again, the sugar goes up. So here, sugar start coming down. This was programmed at 60. I want my pump to stop when my sugar is 60 for 2 hours. This is 1 to 3 a.m. in the morning. You don't have to worry about it. You don't have to wake up. You don't have to beep. Oh, you see that my pump stopped working for 2 hours. Then when the sugar goes up again over 60, it will click and work. So this, as close to normal pancreas as possible, is at least you have protection from hypoglycemia with the new technology. So the other one that we have, some people say, well, I'm type 2, I don't need all this sophisticated program with the pump and the sensors. What can I do? Is anything else simpler? And there's also a newer device called Vigo. Very simple device. This has become like a disposable pump, but it's only for type 2, not type 1, because it does not give you the variation. But if for somebody who takes 4 shots a day, and he said that, I don't want to take these 4 shots a day, they can put this disposable pump for 24 hours. By the end, you just put insulin in it, but that disposable pump, the Vigo, will give you insulin 24-hour basal, and all you have to do is a click, a few clicks to cover the meal. But it doesn't give you the dual bolus and all different kind of boluses that we talked about with the pump. So the simpler device for people who don't have to have the complex pump. So it's a nice, again, newer device. So in answering the question is, are we close to artificial pancreas? The answer is no. We're still far behind, because we can monitor your sugar, we can give you a better delivery of insulin, we can have a sensor that check your sugar all the time and send it to the pump. We have pump now will stop working when your sugar is low, and it's the newest technology. But we don't have this complex mission that the beta cell, the normal pancreas, will do. Because it's not only about insulin delivery, there's an amylin, glucagon. So many of these has to be involved to actually be close to an artificial pancreas. So this is one baby step. So many steps are coming. The recent Diabetes Care had 10 articles on artificial pancreas. So there's more interest in this. A lot of people spending a lot of money to try to come up with better ways of having this artificial pancreas, because it's very difficult. You know when you become what we call a brittle diabetic, you know how frustrating it is. You do all the things you can, but your sugar keep on going up and down. And most of the time it's not your fault. It's just the way we have the pumps or the sensors or the insulin delivery method we have are not perfect. So I'm going to stop here. Just showing here that this closed loop can really have a much nicer sugar in these newer sugar, what's called the closed loop. They have a sensor talking to the pump. So in summary, what we talked about, type 1 is an autoimmune disease, usually younger patients. We see more and more of type 1, I'm surprised, but the one that is rampant is type 2. Type 2, as an end stage, if you have type 2 for over 10 years, you more likely lost your beta cell. And then now you have to act just like type 1, and you have to give insulin like type 1. Delivering insulin with all the things we had in the past, or we having now, give us this flat insulin and a straight line insulin, which is okay. It works for a lot of people, but when you have this brittle diabetes, you need a better way of delivering the insulin. Pumps can give you this basal rate that is up and down, can be programmed anytime you want. But you need somebody who knows. A lot of times people, well, I had the pump, didn't work for me. It's not that it didn't work for you. It's just you didn't know how to handle it, and your doctor didn't know how to handle it. Because a lot of things you can do in the pump. And a lot of times I see people on the pump for 5 years, and I look at it, and 90% of the features are not even activated. So they use it as just a storage device for insulin. So you have to use the pump well. You have to understand what it does. And I showed you all different ways of basal delivery, all different ways of bolus delivery. Dual bolus and 20% and square wave boluses. Majority of pumpers don't even know about this. So they can't use it because they don't know about it. So you're not using the pump to the fullest. And if you are afraid of hypoglycemia, you have this brittle diabetes, or you have a child brittle diabetes, or a family member with brittle diabetes, then the sensors will make it easier, because now you have a 24-hour surveillance that tells you sugar all the time, can protect you from going high going low. You can do something about it. Before, we didn't have anything to do. So I'm going to stop here. Thank you very much for staying late this day, and I'll be happy to answer any questions if you have. Yes?
I have a question, because I have a Medtronic pump and I wear a sensor. And the new pump you're talking about, I thought I had read that it will only suspend insulin if you don't respond to the alarm. Is that correct, or?
No, it will. You can always stop it.
Okay.
It will. If you wake up and say, you know what, I don't want it to stop, you can overcome that suspension.
Okay.
But I think you can, if you want to stop the alarm completely in this pump. You see, I don't wake up because sometimes people with these sensor alarm, after they had it for a month or two, they get sick of it, of the sensor. Because you know what, the whole family, and these are loud. So I'll say, you know what, the neighborhood is waking up on my sensor. So I don't like it. So a lot of times they suspend it. Now with this pump, you don't have to have the sensor even activated in terms of the alarm. You can just silence the alarm and just be comfortable that if it drops, I'm not going to have any insulin until it's over a certain number. You can program that number. You can put it 70 or 80, whatever your level of comfort and how much you respond to hypoglycemia. So it does that.
It will restart on its own.
It will restart on its own in 2 hours or when the sugar gets back to normal. But if it restarted in 2 hours and the sugar is still low, automatically shut down again for another 2 hours.
I picked mine up yesterday.
Very good. So make sure you get all the training right to these pumps. Again, if you don't, it will not be helpful to you. So you are RN, so you're lucky. But some people have these pumps, they don't know what to do with them. Yes?
How is the person who trains trained? Are they doctors or nurses?
So the trainers are people who work for the pump company and are nurses also who knows these pumps. So in our office we have nurses who actually wear pump themselves. So I've seen a lot of trainers even who work for the pump companies. They are on pump themselves, so they know everything about the pumps, and they can easily train somebody. But that takes time. Some patients are there for 3-4 days in a row for a few hours every day before they get comfortable with the pump. And we usually, anybody start on the pump, you need to follow with your doctor, because sometimes people get on the pump and they think that's it, I'm done, I got my pump, see you, 6 months, we don't see anybody. And you say, oh, the pump is not working, of course, because you can't do it on your own. You really need follow up to make the adjustments needed for the pump.
Teachers teach these things?
Yes,
Okay.
absolutely. Everything I told you is
My
there.
doctor prescribes a pump. There will be at that hospital a teacher to teach you.
There's a process of getting the pump. So you cannot just go to the family doctor and say, can you write a prescription for the pump? And you go pick it up at the pharmacy. It's a very difficult process. It has to go through approval. So it has to be a doctor who knows pumps very well, who have all the forms needed. You usually have to do forms. You have to do classes of carbohydrate counting. And we do at Garden City Hospital sometime with this. You have to do the carbohydrate counting classes, because if you don't know to count carbs, the pump is not going to be helpful to you. And then you have to be trained on the information about the pump. Then you send the information to the insurance, and once it's approved, then somebody may come to your house or bring you to the doctor's office and do the training. So not every hospital don't have trainers on the pump. And trainers have to come either from an endocrinologist's office or from the company that supplies the pump. But hospital don't have anybody who knows. Actually, people on the pump, when they go to the hospital, first thing they do, what is this? They just take it off, and the people are usually really having a hard time. I always struggle with the hospital. When my patient on the pump go to the hospital, I have to beg the hospital, please let them stay on the pump. Because otherwise, you just don't know how to handle it. Because if you are on the pump, you're pretty diabetic. Hospital cannot handle pretty diabetic well. Yes?
I have a question. I haven't done a pump. The fact that, that insulin, even though it's 1/10 or whatever it is per hour is going through you, doesn't that make you more likely to get insulin reactions as opposed to someone who's taking shots?
The opposite, exactly what you're saying. So the question would be that if you have a pump that gives you insulin all the time, are you more likely to have hypoglycemia compared to somebody taking shots? So if you have diabetes, you have to take 2 shots. The quick acting, that's not a problem, but the long acting one. If you take the long acting one, you're stuck with that insulin for 24 hours. So you can't make, so if your husband got a shot of 24-hour insulin like Lantus or Levemir, and then he decided not to have breakfast, or not to eat, or he becomes sick during the day, you start with that insulin. But the pump is the opposite, actually less chance of getting hypoglycemia because you're getting just a little bit at a time. This basal insulin, again, if it's programmed right, some people say, I have it, it's giving me hypoglycemia. It's not the fault of the pump, it's the fault of the doctor who did not adjust that for you. You can prevent hypoglycemia with the pump because you can suspend it anytime and you're not taking
The
insulin.
main key is having that right basal rate.
Right basal rate at a different time of the day. Because that's where people make mistakes sometimes. They put the basal rate so high so that they have to get boluses because they're comfortable. They say, no, I have to have my basal rate high. Then when it's high, they wake up with sugar of 50 or 60. Oh, I can't, I have to eat, so I can't give boluses because my sugar is low. Then it's a cycle all day. Now they eat. They didn't take boluses. What happened an hour, 2 hours later, the sugar at 300. Now the pump tell them take 7 units, and they crash. So if you start the day wrong with the high basal rate, you pretty much screw the rest of the day. So adjusting the right basal rate becomes the most important thing with pump handle.
And that leads you to a high A1C, right?
Of course. The worst you can have is have a high A1C and a lot of low sugars. If you have unknown sugar, you can say, what hypoglycemia? That means you're doing something wrong, and it has to be download and download and download till you know what is wrong, and you can fix it. Yes?
So the pump depends upon the user. Carb counting?
Yes, you have to count, you have to know how much carb are you eating to enter the pump.
But you can't do the pump with, what you call that, the older method.
The exchanges, you can.
Okay.
It's actually, you can do, some people want it simpler, you can actually do 1 unit for one exchange or 2 units for one exchange. You can do by exchanges, yes.
Okay.
We like the carb because you can see exchange is this, one exchange is 15 grams. What if you need 12? Is how much of the exchange is that? So you can do an exchange to make it simple, but it's a lot better, more efficacious if you do it with the grams.
Yeah, I'm finding that if I do carb, I've taught both. And I did exchanges for many years, and then was taught carb counting. I find that just doing carb counting shows me the carbohydrates, and I tend to ignore the non-carbohydrate foods. But they have calories.
That's a great question. But I'll show you some of these sensors. I have one engineer also, young man, who's after breakfast, his sugar's running in all the time. He puts 60 grams of carb, and his sugars are perfect on weekdays. Saturday, Sunday, his sugar after breakfast go to 400. He says 60 grams of carb. But his 60 grams of carb on a weekday is a bagel. 60 grams of carb on a weekend is McDonald's with 60 grams of fat. So it is important to actually to adjust that with the fat. You have one last question?
Thank you so
There's no
much.
food that's no carb. Every food has carb.
Yes, exactly. It's always,
I found that out with my friend that got a pump. And that's what she was checking, putting.
You can see it, yeah.
She said everything,
Has it-
salads, but people don't know that.
people get surprised sometimes when we do the sensor, and a lot of times they say, well, I'm just having a little oatmeal, I'm not taking any insulin for it. It's just a little tiny oatmeal can raise your sugar to 300 easily. I mean, 4 ounces of orange juice can raise your sugar to 300. So we just underestimate what the food will do to you. And thank you. Oh, I'm sorry. One last question?
I just have a comment.
Yes.
I've been on the pump for 31 years, and I just love your enthusiasm because it is
Oh, thank you.
it is great. It's just I learned a lot today, even though like I said, I've been on it for a while. But your enthusiasm is just.
Oh, thank you.